Assalamu alaikum. Thank you very much, Dr. Awais, for a nice introduction, and I'm really grateful to PIMA for inviting me for this talk. And I'm humbled to present in front of the great teachers, Professor Ijaz Vohra and Professor Najmul Islam. So, can I have my slides? And thank you, my former speakers, Dr. Saeed Meher and Dr. Elias Kar, for making my life easy, because you have discussed quite a lot, and I can focus more on the cutting edge innovations in diabetes management. So, as we have already discussed that diabetes is a complex chronic illness that requires continuous medical care with multifactorial risk reduction strategies beyond glycemic control. And there is significant evidence that exists to support a range of interventions to improve diabetes outcomes. Diabetes is on the rise. So more than 546 million people worldwide have diabetes. In Pakistan, you can see with 33 million people with diabetes stands number 3. And the two countries which are above us are actually those countries which are already have huge populations than ours, placing us in terms of percentage on the top rank. Diabetes leads to cardiovascular disease, kidney failure, blindness, and lower limb amputations. And these are the hard outcomes that actually we want to avoid when we are managing our people with diabetes. Causes of death, heart disease stands the highest percentage, 68%, strokes another 16%. And this is the pathogenesis of type 2 diabetes, where there are multiple defects at different levels of our system. And therapies are actually trying to focus those areas of defect, and thus therapies have been evolved over last a decade or so remarkably, that had led to a paradigm shift in diabetes management. When it comes to type 2 diabetes, a patient, well, by the time the patient develops diabetes, they have already lost 50% of their beta cell mass. And that loss actually continues over progressive years, which means that diabetes is a progressive disease, and whatever therapies you start at point 1 may not be effective by 2 years down the line or later on. Thus, the therapy of type 2 diabetes has to escalate. And as Dr. Elias has already pointed out, that lifestyle therapy is something that forms the basis of diabetes management throughout the course of a patient's life. And then oral monotherapy, oral combinations, and then you progress to injectables, which are incretin mimetics, and then insulin treatment is needed in many people with type 2 diabetes. So my question to you is that what is true regarding incretins? Can we have a show of hands? So it releases insulin independent of glucose levels. How many think that this releases insulin independent of glucose levels? One hand over here. Increases glucagon levels? None. Works at the GI tract alone? Approved as anti-obesity medications? Can we have a show of hand? What is true regarding incretins? And only available as injectables? Okay. So this is actually true regarding incretins. We know that incretins release insulin dependent of glucose levels. So they are glucose dependent insulin release. They reduce glucagon levels. They work at various sites, central nervous system and GI as well. And they are approved as anti-obesity medications, and they are available, at least one formulation is available in an oral form as well. So incretin effect, you have been listening to this effect for last, I think, a decade or so. Incretin effect is something when you are taking glucose through the oral route compared to if you are taking it through an IV route. The level of insulin response is remarkable through the oral route. And those are the incretin hormones, which are GLP-1 and GIP. And incretin-based therapies are GLP-1 receptor analogs and then DPP-4 inhibitors. DPP-4 inhibitors will actually break the enzyme DPP-4, which inactivates the endogenous GLP-1, and GLP-1 receptor antagonists are those analogs which are mimicking the GLP-1 receptor, GLP-1 native GLP-1, and thus are leading to various effects that improve glycemic control and other parameters as well. What was interesting is that these molecules were found to improve the major adverse cardiovascular events. The major adverse cardiovascular events that include non-fatal MI, non-fatal stroke, death from cardiovascular diseases, and heart failure hospitalization. And this is meta-analysis, a recent one, from all the trials which were looking at the cardiovascular outcomes of GLP-1 receptor analogs, and you can see that these are favoring GLP-1 receptor analog compared to placebo. Similarly, the renal outcomes, a composite of renal outcomes that include reduction in eGFR levels, need for renal replacement therapy, and renal death, death from renal causes, all were shown to improve through these GLP-1 receptor analogs. And then there are newer agents in the pipeline. You must have been aware of dual GLP-1 GIP analogs, which is available by the name of tirzepatide, already been approved for type 2 diabetes and as an anti-obesity medication. And then there is work going on triagonists, which are GLP-1, GIP, and glucagon triagonists. There are molecules which are underway. You can see that dual agonist is already marketed, but the triple agonists are under phase 1 clinical trials. Okay, so coming to the other agent which is in use in clinical practice, the SGLT2 inhibitors. And these are novel agents and which do all of these except. So one of these is false. Can you identify which one? So A, these lead to glycosuria and natriuresis. These lead to insulin-independent action. They lead to weight loss, and they enhance cardiovascular risk, and they lead to reduction in albuminuria. So what is false in all these statements? Enhanced cardiovascular risk. Thank you. So these do not lead to enhanced cardiovascular risk, rather lead to improvement in cardiovascular risk scores. This is the normal glucose homeostasis in our kidney. 180 gram of glucose is filtered per day, and all of this is actually absorbed by these transporter proteins, SGLT2 transporter protein and SGLT1 transporter protein. And virtually in a person who is not having diabetes will not be releasing any glucose excretion in the urine. What happens in people with type 2 diabetes is that these transporter proteins are upregulated, and kidneys are actually hyper-absorbing glucose. So this threshold moves on to something like 220 gram of glucose. And thus, if you could just block this transporter protein, SGLT2 transporter protein, you can actually increase glycosuria, but at the same time lead to reduced glucose reabsorption and improve glycemic control. And these are the agents which are working independent of the beta cell function. So whatever insulin reserve or insulin resistance a patient has, these molecules will continue to work because these are working at the kidneys. And thus, SGLT2 inhibitor, the CVOT, the cardiovascular outcome trials have shown many beneficial outcomes in terms of reducing the major adverse cardiovascular events, similarly reducing the risk of hospitalization for heart failure and cardiovascular death. All for empagliflozin, canagliflozin, dapagliflozin, there are trials. And then if you look at the life expectancy in people with diabetes, and this is something which is already discussed by Professor Saeed Meher in his talk, diabetes reduces the life expectancy. If a person with diabetes has coexisting cardiovascular disease, there would be a further reduction by 12 years, and with diabetic kidney disease by 16 years. And if we could just have therapies that improve those outcomes, and you can look at SGLT2 inhibitor trials on renal function worsening. These are again all the major SGLT2 inhibitor molecules that are available, and cardiovascular outcome trials have already been done. And these are the renal outcome trials, and all of these show that they improved renal function, reduced the risk of end-stage renal disease or renal death as well. This is again a trial by on heart failure hospitalization. These were the trials which are specifically dedicated to diabetic and non-diabetic individuals, and showed that these agents reduce the risk of heart failure hospitalization and reduce the cardiac death as well, both for empagliflozin and dapagliflozin. And similarly, empagliflozin on heart failure hospitalization with preserved ejection fraction. So this was something which we label as diastolic dysfunction. There weren't any specific therapies that could improve the outcomes, but empagliflozin eventually showed through this trial that there was almost a 21% reduction in the primary outcome of cardiovascular death or heart failure hospitalization. Thus, these agents have been registered and approved for use beyond glycemic control and beyond benefits for type 2 diabetes, even for people who do not have diabetes with cardiovascular disease and heart failure. These agents are approved for use. Important to note that you cannot use these agents in type 1 diabetes and somebody who is at risk of diabetic ketoacidosis. And similarly, okay, so this recommendation has actually changed. And it has been approved for chronic kidney disease as well, based upon the recent EMPA kidney trial. Similarly, dapagliflozin, beyond the use of in type 2 diabetes, it has been approved for use in heart failure hospitalization patients to reduce the risk of heart failure hospitalizations. Similarly, reduce the risk of cardiovascular death and hospitalization for heart failure in people with reduced ejection fraction, and for somebody who is having a kidney disease, irrespective of the diabetes status. So these have wider implications and indications in people with or without diabetes who have underlying cardiovascular disease or kidney disease. And there are emerging data that suggests that in people with fatty liver disease, these agents are beneficial, and we will be coming up with more such trials that are published and will show the improvement in and metabolically associated steatotic liver disease as well. And this is something that Professor Saeed Meher has already discussed. Goals of care in managing people with diabetes is to improve their quality of life and reduce the risk of complications and prevent the complications. And you need to look at the patient comorbid. So if the patient is having a chronic kidney disease or heart failure or a cardiovascular disease, your agent of choice after metformin would be either an SGLT2 inhibitor or GLP-1 analog therapy. Then coming to what is happening on the scene of insulin, especially with regards to people with type 1 diabetes who are absolutely insulin deficient, we have got ultra-long-acting insulins available in market. These are insulin degludec and U300 insulin glargine, which have a very stable curve beyond 24 hours of coverage. And similarly, there are ultra-rapid acting insulins available in different markets in the West. We still do not have those, but those are ultra-short acting insulins available as well. Then glucose meters. When it comes to managing people with diabetes, especially those who are on insulin, people with type 2 or type 1 diabetes, we all know that glucose meters are a major technological advancement that occurred in past few decades. And it leads to help the patient and the healthcare provider to make treatment decisions and modifications, can help them identify what kind of impact they are having in terms of their diet and exercise on their glucose levels, treatments, and how to adjust those treatments. Similarly, identification of hypoglycemia in a timely manner as well. So there has been advancement in when it comes to monitoring of blood glucose levels. So can any one of you identify which place is this, which is hidden behind these bars? Which place is this? Can anyone identify? No, it's difficult to identify? Okay, so let me share some more part of this scene. Can anyone now identify which place is this? Okay, so this is it. This is Paris, and you can see that if we are having self-monitored blood glucose alone, we can actually miss highs and lows. So this is the data. You can see the patient is testing his blood glucose values at these 4 points in time. And all those 4 values are actually well within the range. But when it comes to unnoticed highs and unnoticed low, those are not evident on these glucose monitoring devices. So you can see that when we come to an A1C value, we rely a lot on A1C values for patient treatment and management. A1C of 7% could have many faces. A patient with A1C 7 would be this patient who is falling 100% of the time in range. So this would be that patient who is just treated with metformin and following all those lifestyle factors that Dr. Ali Asghar has pointed in his talk. Or a patient could be 70% of the time in range, 25% high, 5% low, and such kind of curve is there on his CGM. Or a patient could be 40% in range, 20% low, 40% high, but still having 7% A1C. which means that for many patients, A1C alone will not be a good tool, and even self-monitoring blood glucose alone through glucometers will not be a good tool to definitely tell us what is happening to that patient. And thus there is role of CGM devices, the continuous glucose monitoring devices. A few devices are available for our use in Pakistan as well, and these are devices by Libre, and then these are Medtronic, Abbott, and Dexcom devices. And this is something which is kind of a new thing. This is implantable CGM device which can give you data over the next 6 months. So these are technological advancements. When right now they are costly, but over years we all know that technology, when it comes for the first time, it's costly, but over time the cost goes down, and more people will benefit from it. Similarly, this is the mechanism. So these devices are actually testing glucose in the interstitial fluid, and this is called as sensor glucose values. And then these are the insulin pumps, continuous subcutaneous insulin infusions that are a very good device for people with type 1 diabetes, where they can ensure 80% time in range. Different devices are available from Medtronic. These are the tubeless pumps which do not require a tubing inside the skin. So you can see that over here there is a tube and the insulin reservoir, and the insulin is delivered through that tube. This needs to be changed every 3 days. And then these are the bionic pancreas systems, which are having both insulin and glucagon chambers available, and these are something that will be trying to mimic what is happening through our pancreas, the normal pancreas. And then these are again some advances that are happening, and these insulin patches, smart insulin patches, will be undergoing clinical trials from next year. These have micro needles which contain insulin loaded in the polymeric matrix, and this is responses. This is assessing glucose through the glucose oxidase method, and will only release insulin in response to a high glucose level. So the fear that we all have when we are prescribing insulin to our patients is hypoglycemia. And these insulin polymers will actually ensure preventing those hypoglycemias, because these will be releasing insulin only in response to a certain glucose level. So these are glucose responsive, and this will be a small device, a nanotechnology that will be in use. Similarly, once weekly insulin is something that is talk of the town as well. It is still awaiting its FDA approval, but once weekly basal insulin is in formulation, you will be hearing more about this in upcoming months and years. Again, a new advancement that is happening in research settings is insulin islet cell transplantation for type 1 diabetes. Islet cell transplantation is something when you have a non-diabetic disease donor, and the islet cells are acquired from that pancreas, and then through the portal vein in the recipient of type 1 diabetes, it can be transplanted. People can have 2 times islet transplantation, and that have improved many parameters of people with type 1 diabetes, especially those who have brittle diabetes and very fluctuating glycemic controls. So, and last but not the least, you might have been hearing and coming across patients who are saying, "Doctor, there's one injection that cures diabetes. Can you give me that injection?" So this is teplizumab, which is not for everyone who is having diabetes. Even for type 1 diabetes who already have diabetes, this will not work. This is a monoclonal antibody that is approved for treatment indicated to delay the onset of stage 3 type 1 diabetes in people with stage 2 diabetes, type 1. So for type 1 diabetes individuals, those type 1s whose families have already been screened and they are found to be having islet cell antibodies in their systems, and you keep on monitoring them with a glucose tolerance test, looking for whether they are having pre-diabetes, and then they will progress to type 1 diabetes. So that stage 2 type 1 diabetes is something which we understand pre-diabetes in people with type 2 diabetes. So only for those individuals who have islet cell antibodies and who have pre-diabetes, you can use this teplizumab, which will delay the onset of type 1 diabetes by almost 3 years. So 3 years benefit they can get by delaying their type 1 diabetes onset. So this is my take-home message. The latest anti-diabetic agents have demonstrated enormous cardiovascular and renal benefits through their pleiotropic effects, and these are the effects beyond glycemic control. So these drugs were designed to improve glycemia, but later on were found to be beneficial in cardiovascular outcomes and renal outcomes. The management of type 2 diabetes has actually moved away from a glucose-centric approach to an approach that targets comorbidities and cardiovascular and chronic kidney disease risk reduction. And thus the role of GLP-1 analogs and SGLT2 inhibitors need to be emphasized further. Major advancements in monitoring and insulin delivery systems are revolutionizing the care of people with type 1 diabetes, and there is hope for delaying the onset of type 1 diabetes in people with stage 2 disease. Thank you very much for your patient listening.